Welcome back to the deep dive. Today, we're tackling a big one, the brain, and specifically, what happens when things go wrong. We're diving straight into Chapter 16, Disorders of Brain Function, from Porth's Essentials of Pathophysiology.
Exactly. And our goal here is pretty straightforward.
Yeah.
To give you a clear, usable framework for this really dense chapter. Because, whether it's trauma, lack of oxygen, infection, the damage often follows these common pathways. We're talking ischemia, edema, and that big one, rising intracranial pressure.
Yeah, that roadmap is key. So let's start where clinicians start. If you suspect something's wrong with the brain, first check, level of consciousness. How does the chapter actually break down something like just being awake?
It does it really nicely, actually. It splits consciousness into two parts you absolutely need. First, there's arousal and wakefulness. That's your basic ability to respond. Think the reticular activating system, the RAS, and the hemispheres working together.
Okay, so that's the lights are on part.
Right. But then you need content and cognition.
Right.
That's your awareness, your thoughts, your orientation. That relies heavily on the cerebral cortex. You need both firing for full consciousness.
And when they're not, that's when we see that slide downwards. Confusion, maybe lethargy.
Exactly. Confusion, where thinking gets fuzzy.
Yep.
Lethargy, where you're drowsy but, wake up if someone talks loudly. Then it progresses. Obtundation, stupor, where you need really strong, painful stimuli to get a response.
Yeah.
And finally, coma. No response.
And to make that less subjective, there's a scale everyone uses bedside, right? The GCS.
The Glasgow Coma Scale, yeah. It's the standardized tool. It looks at three things: eye-opening, motor response, and verbal response. Scores range from 15, which is fully conscious, down to 3. That's the lowest possible score. Anything below 8, generally that indicates severe injury or coma.
Okay. Now, something crucial for prognosis is how the brain fails. If the injury starts up high, supratentorial, it doesn't just shut down, does it? It follows a pattern.
It does. It follows this predictable downward path. The rostral to caudal progression. Basically, the damage marches down from the cerebrum towards the brainstem. And the clinical signs tell you how far it's gotten.
So like stage 1?
When it hits the diencephalon think thalamus, hypothalamus consciousness starts to dip, pupils get small but still react, breathing might get that Cheyne-Stokes pattern. And importantly, you might see abnormal flexion posturing. That's decorticate rigidity, arms pulled in towards the core.
Okay, pulling in. Then what happens if it pushes down further, say, to the midbrain?
Then it gets much more serious. You're likely in a coma. Pupils become fixed, mid-sized. Breathing might switch to this rapid, deep pattern called central neurogenic hyperventilation, and the posture changes dramatically. Now it's extension posturing, or decerebrate rigidity. Arms and legs extend stiffly. That signals really severe brainstem problems.
And the last stop?
The medulla. That's the final stage. Deep coma, fixed pupils, the body goes flaccid. You lose protective reflexes like gagging and coughing. Respiration becomes erratic, ataxic, or just stops. Apnea.
That progression really shows how vital but vulnerable the brainstem is.
Let's zoom in now, right down to the cells. Because
move.
often it's not the initial hit, but the chain reaction afterwards. We had to get hypoxia and ischemia straight.
Yes, people mix them up all the time, but the difference is critical. Hypoxia is low oxygen, simple as that. But crucially, blood is still flowing. Neurons can handle that, briefly. Ischemia, though, that's different. That's reduced or interrupted blood flow. No oxygen, no glucose, and no way to clear out toxic waste. It's far, far worse.
And that lack of flow, the ischemia, kicks off this internal self-destruct sequence, excitotoxic injury.
Precisely. And the main culprit is a neurotransmitter that's normally essential, glutamate. It's the brain's primary excitatory signal, vital for learning, memory.
But in ischemia,
In ischemia, the cleanup mechanisms fail. Glutamate floods the synapse, keeps hammering on its receptor, particularly the NMDA receptor. It basically forces the receptor's channel open.
opening the floodgates for calcium. A massive, uncontrolled wave of calcium pours into the cell. This is the notorious calcium cascade. And that calcium overload, it activates enzymes that break down proteins, creates free radicals. The cell essentially eats itself from the inside out. Irreversible damage.
Wow, so the brain's own chemistry turns against it. Does this cell swelling then feed directly into the mechanical problem, the pressure inside the skull?
Absolutely. The swollen cells take up space. And that leads us right into intracranial pressure, ICP dynamics. Remember the Monro-Kellie hypothesis? The skull is a fixed box containing brain tissue, about 80%, blood, 10%, and cerebrospinal fluid, CSF, 10%.
Right, so if one goes up, like swelling or bleeding, it adds volume.
Something else has to decrease to compensate. The body first shunts CSF out, then tries to squeeze blood out of the veins. Normally, ICP stays low, like 0 to 15 millimeters of mercury, but compensation has limits.
And when those limits are breached, the rising pressure crushes blood vessels.
Exactly. It reduces blood flow further. We track this using cerebral perfusion pressure, CPP. It's basically, arterial pressure minus ICP. CPP equal MAP, ICP. If cyclothy drops below, say, 30 millimeter Hg, the brain isn't getting enough blood. You get global ischemia.
And if that ischemia hits the brainstem itself, that's when we see that really late, scary reflex.
Yeah, switching reflex, yes. It's a late sign, meaning herniation might be imminent. The brainstem, sensing its own ischemia, triggers this massive sympathetic response. You see severe hypertension, a widening pulse pressure that's the gap between systolic and diastolic, and paradoxically, bradycardia, a slow heart rate. It's the body's desperate final attempt to force blood into the ischemic brain.
Okay, before we move to causes, quick clarification on edema, the swelling itself. Two types.
Two main types, yes. Vasogenic edema is fluid leaking out of damaged blood vessels into the space around the cells. The blood-brain barrier fails. Common with tumors, inflammation. Cytotoxic edema, on the other hand, is the cells themselves swelling up. This is what happens in ischemia when the cell's ion pumps fail due to lack of energy.
Got it. And if that swelling, that pressure, isn't controlled, brain herniation, tissue gets squeezed where it shouldn't. Just from memory, that classic sign one pupil suddenly blows, dilates. What pattern is that?
That strongly suggests uncal herniation. The uncussed, part of the temporal lobe, gets shoved downwards, squashing cranial nerve the third, the oculomotor nerve, on that same side. That's why the pupil dilates. It's an emergency.
All right, let's shift to the major causes, starting with physical force. Traumatic brain injury, TBI. The chapter makes a key distinction here. Primary versus secondary injury.
Yeah, that's fundamental.
Yeah.
The primary injury is the damage done at the moment of impact. The bruise, contusion, the tear, laceration. It's immediate, mechanical. But often, the real damage comes later. That's secondary injury, the brain's reaction to the initial trauma. Things like swelling, edema, lack of oxygen, hypoxia, bleeding, hematomas, all the stuff we just discussed.
And the way the injury happens often involves the brain sloshing inside the skull, right?
Yeah.
The coup contre coup thing.
Exactly. You get hit in the front, that's the coup injury. Your brain slams against the front of the skull, then it rebounds, hitting the back of the skull, the contre coup injury. So you can have damage at two opposite points from one blow.
Now, those secondary hematomas, the bleeding, one type is especially notorious for being fast and having that tricky lucid interval. Which one?
That's the epidural hematoma. Epidural means above the dura. It's usually arterial bleeding, often from the middle meningeal artery tearing. Arteries bleed fast, under high pressure. The danger is that classic pattern. Patient gets knocked out briefly, wakes up, seems fine for maybe hours. That's the lucid interval. And then crashes rapidly as the hematoma expands and compresses the brain. It's a surgical emergency.
Okay, arterial fast lucid interval. What about the other main type, subdural?
Subdural hematoma. Sub means below the dura. This is typically venous bleeding, usually from tearing of the bridging veins that cross the subdural space. Because it's venous, it's slower. Much slower.
So it might not show up right away.
Exactly. It can be acute, showing up in hours to days, subacute, days to weeks, or even chronic weeks to months. Chronic subdurals are a big issue for older adults or people with alcoholism because brain atrophy can stretch those bridging veins, making them fragile. Even a minor bump can tear one.
Okay, shifting from trauma to vascular problems, stroke or cerebrovascular disease. Our brain's plumbing has a built-in backup system, doesn't it? The circle of Willis.
It does, and it's incredibly important. It's a ring of arteries at the base of the brain where the major vessels connect. This anastomosis provides collateral routes. If one main artery gets blocked further down, blood might still be able to sneak around through the circle of Willis to reach the threatened area. It can sometimes limit the damage.
And the brain's pretty smart about managing its own blood supply, too. Autoregulation.
Very smart. Cerebral blood vessels can constrict or dilate to maintain relatively constant blood flow, even if your systemic blood pressure goes up or down, within limits, of course. And chemicals play a role, too. A buildup of CO2, for instance, is a powerful signal for cerebral vessels to dilate, trying to increase flow and wash it out.
Now, most strokes, the vast majority, like 87%, are ischemic, meaning a blockage. And related to this is the TIA, the transient ischemic attack. Why is that so critical if it just goes away?
Because it's a huge red flag. A TIA is basically a mini stroke. You get temporary focal symptoms, weakness, numbness, speech trouble that resolve completely, usually fast. But it means there's underlying disease, often a clot forming or unstable plaque. The risk of having a major permanent stroke soon after a TIA is incredibly high, especially in the first day or two. It's a warning siren.
During the actual ischemic stroke, there's the area that dies quickly, the core, but around it.
Around the dead core is the ischemic penumbra. This is crucial. It's brain tissue that's getting some blood flow, but not enough to function normally. These cells are stunned, metabolically stressed, but they aren't dead yet. They're salvageable if you restore blood flow quickly. That's the target for treatments like clot-busting drugs. Time is brain.
Okay, so that covers blockages. What about the other 13%? The hemorrhagic strokes? Bleeds.
Right, this is when a blood vessel actually ruptures inside the head, often due to high blood pressure weakening an artery or sometimes an aneurysm bursting. A particularly dramatic one is aneurysmal subarachnoid hemorrhage, or SAH, bleeding into the space around the brain.
And the classic way that presents.
It's often described as the sudden onset of the worst headache of life, thunderclap headache. Because blood is irritating the meninges, you also often get neck stiffness, nuchal rigidity, and light sensitivity, photophobia.
So, for any stroke, ischemic or hemorrhagic, the key features are sudden onset, focal symptoms affecting a specific function, and usually unilateral, right? One side of the body. And the specific symptoms depend on which artery is involved. Like, what's the classic picture for the middle cerebral artery, the MCA?
The MCA is the big one. Supplies a huge territory. A typical MCA stroke causes contralateral hemiplegia weakness or paralysis on the opposite side of the body, usually worse in the face and arm than the leg. And critically, if it hits the dominant hemisphere, usually the left, you very often get aphasia problems with producing or understanding language. Okay, moving on to infections within the central nervous system. Two big categories, meningitis and encephalitis. Need to keep those straight.
Right. Meningitis is inflammation of the meninges, the coverings of the brain and spinal cord, and the CSF space. Encephalitis is inflammation of the brain tissue itself, the parenchyma.
Exactly. And with meningitis, a key diagnostic step is the lumbar puncture of the spinal tap to analyze the CSF. That helps tell you if it's likely bacterial or viral.
How does the CSF look different?
Bacterial meningitis typically gives you cloudy, purulent CSF. Protein levels are usually high, and glucose levels are low because the bacteria are eating the sugar. Viral meningitis tends to be less severe. The CSF might have more lymphocytes, but protein is only mildly elevated, and crucially, the glucose level is usually normal.
Clinically, besides the fever, headache, stiff neck, how do you test for that meningeal irritation at the bedside?
There are those classic signs. Kernig sign.
Oh.
You flex the patient's hip and knee, then try to straighten the knee. It causes pain and resistance in the hamstring.
Yeah.
And Brzezinski sign. If you passively flex the patient's neck forward, their hips and knees automatically flex too. Both point to irritated meninges.
Okay. Now, encephalitis, often viral, like herpes simplex virus. Because it hits the brain tissue directly, the symptoms are more specific than just feeling sick, right?
Definitely. You still get fever, headache, maybe confusion, but because the brain is inflamed, you're much more likely to see focal neurological signs. Seizures, bizarre behavior, specific paralysis, things like that. It depends on which part of the brain is affected.
All right, let's talk about brain tumors, neoplasms. They can start in the brain, primary tumors like gliomas, astrocytomas being common in adults, or they can spread to the brain from elsewhere, metastatic.
Right. But regardless of the tumor type or origin, many of the general symptoms come back to that same problem we started with. Increased intracranial pressure. The tumor takes up space.
And that pressure causes those characteristic symptoms.
Yeah, the chapter highlights things like headaches that are often worse first thing in the morning and might get better after being upright for a while. Also projectile vomiting, sometimes without nausea, and papilledema swelling of the optic nerve head when you look in the eye, a direct sign of high ICP.
And then the focal symptoms depend entirely on location.
Totally. A tumor pressing on the motor cortex causes weakness. One in the occipital lobe causes visual disturbances. Temporal lobe, maybe seizures or auditory hallucinations. It's all about where it grows.
Okay, final major topic. Electrical storms in the brain. Seizure disorders. First, let's clarify terms. Seizure versus epilepsy.
Good point. A seizure is the event itself, a sudden, abnormal, excessive electrical discharge from neurons in the brain. Epilepsy is the condition, a chronic disorder characterized by recurrent, unprovoked seizures. You need more than one seizure, generally, for an epilepsy diagnosis.
And how are they classified now? It's not just grand mal, petit mal anymore.
No, the main system now focuses on where the seizure starts. Focal onset seizures begin in just one area, one hemisphere. They can happen without impaired awareness. The person is awake and knows what's happening. Sometimes that's the classic aura, like a strange smell or visual distortion, which is actually a small focal seizure itself. Or they can be focal onset with impaired awareness. Consciousness gets altered. These often involve the temporal lobe and might feature automatisms, repetitive, non-purposeful movements like lip smacking, chewing, or fiddling with clothes.
Okay, so focal is one spot. What's the other main type?
Generalized onset. These seem to involve both hemispheres right from the start. Consciousness is usually lost immediately. This category includes the seizure type most people picture, the tonic-clonic seizure, formerly grand mal, with stiffening then jerking. But it also includes others like absence seizures, petit mal, those brief staring spells, often in kids where they just zone out for a few seconds.
In the really dangerous situation.
Status epilepticus. This is a neurological emergency. It's basically defined as continuous seizure activity lasting more than 5 minutes, or having multiple seizures back-to-back without regaining consciousness in between. It's dangerous because prolonged seizures can cause brain damage from hypoxia, metabolic stress, and potential aspiration or respiratory failure. Needs rapid treatment.
One last crucial point here. Not everything that looks like a seizure is an epileptic seizure.
Absolutely essential point. Psychogenic non-epileptic seizures, or PNES. These are episodes that can look very much like epileptic seizures, convulsions, unresponsiveness, but they don't have the characteristic abnormal electrical activity on an EEG. They stem from psychological distress or trauma, not abnormal brain electricity. It's a critical differential diagnosis. Hashtag tag outro. So we pull this all together looking back at the chapter. I think the big takeaway is really about those common pathways, whether it starts with a bang from trauma or a blockage in a vessel or an infection or even a tumor growing slowly. The way the brain ultimately fails often comes down to a few predictable things: rising ICP, swelling, lack of blood flow, and that destructive excitotoxic process.
Yeah, understanding those core mechanisms, ICP, edema, ischemia, excitotoxicity, really gives you the framework to understand all these different disorders. It provides that roadmap.
It really does. And it brings up this interesting paradox, doesn't it? The brain demands so much energy, it's so metabolically active, but that makes it incredibly vulnerable. Think about glutamate again, essential for thinking, learning, memory, our highest functions. But let things go slightly wrong, let ischemia disrupt its regulation, and it becomes the primary weapon the brain uses against itself through that calcium cascade. It really highlights just how fine the line is, how tightly everything needs to be controlled to prevent the brain from essentially causing its own destruction.
A powerful reminder of the delicate balance inside our heads. Thanks, as always, for navigating this complex territory with us, and thank you for joining us for this deep dive.
Hope this helps you tackle Chapter 16. We'll catch you on the next deep dive.